Welcome everyone to our program this evening. I think we have a critical number here. We'll get started. So good evening, everyone. My name is Susan. Start my video. Excellent. There we go. Good evening. My name is Susan. My pronouns are she and her, and I'm part of the community engagement team here at the Museum of Science. So welcome to our program, Vaccination Decisions, Rolling Out the Vaccine. I'm going to start with just a few housekeeping items and then we'll begin the official program. First of all, I want to say thank you to the Janssen Pharmaceutical Companies of Johnson & Johnson for supporting the museum's COVID-19 initiatives and our upcoming exhibition. If you'd like closed captions in English are available by clicking on the closed caption button that you probably see at the bottom of your screen. So if you press on that, you can get them in English. Captions in Spanish are also available. Los subtítulos en español están disponibles haciendo clic en el enlace que aparece en el chat. Esto abrirá una ventana web con subtítulos en español. Please click on the chat button at the bottom of your screen. If you do that, we'll be able to give you some information throughout this evening, some helpful links. And if you have questions throughout the panel portion, please type them in the chat to me, Susan Heilman. You'll see that's one of the only people you can chat to. After about 45 minutes, our panel is going to conclude and we'll begin the discussion portion of our event for those that would like to stay and participate. Therefore, we're in a meeting format for the entire program. So we're going to work on keeping you muted and your video off for this panel portion, and we'll spotlight the speakers for you for ideal viewing. If you'd like to stay and participate in the discussion afterwards, please just remain as you are at the end of the panel, and we'll give you further guidance then. And now, with any further ado, it's my pleasure to introduce the president of the Museum of Science, Tim Ritchie.
Thank you, Susan, and thank you so much to everyone who's joined us, to the panelists. This is an important time for our community. Have you ever seen a time when science was more public or participatory? Every one of us makes science-based decisions all the time right now, and we know it. We know when we decide to wear a mask or not wear, to go to a restaurant or not. We know all these decisions, and especially the one about whether to get a vaccine, how to get it. These are science-based decisions. And that's where the Museum of Science wants to be, is to help our community make informed and good decisions about science and technology. We firmly believe that science is, let me put it simply, awesome. It is awesome in its ability to help us solve problems, to help us live humanely, to help us live sustainably, to create a better future for our planet and for each other. So this is why we exist. And the importance of the vaccine information right now couldn't be more important. For some, it is literally a matter of life and death. If people were to follow the science, there would be so much less death and sickness in our community. And the choice to not do so has had profound consequences to our nation and to our community. And now we have the vaccine rolling out. What is the right information? What is misinformation? How does the community distinguish between the two? How do you make great decisions for yourself? Well, all of those things are important. But the most important thing really is for us to listen to our community to know what information do people really need. This is essentially a listening session because it's one thing to have information, but it's another thing to understand the questions that people are asking. So this listening session, this forum is one of 3 that we're doing called Vaccination Decisions. The first one is going to be on distribution because that is happening right now. And there's a lot of questions about it, and a lot of misinformation, a lot of hopes and desires, and we want to hear what your questions are. The next one is really going to be on the clinical trials. And you might say, why would you do that second? And that is because as people are able to get the vaccine, we want them to have the information they need to know whether they can trust it. And of course, we believe that they can, but there are legitimate and honest questions about them. And finally, we want to say, in the future, how do we live as a society after people are vaccinated? Still, what does a COVID future look like? To what extent is it a post-COVID future, and to what extent is it really not? But it's something we live with, like we do with the flu, for instance. All of these things we'll talk about over the seasons or the months to come. But for tonight, it's my pleasure to hand things over to our moderator, Angus Chen. Angus is a health and science reporter with WBUR Public Radio. He was previously at WNYC Public Radio in New York and NPR in Washington, D.C. He has been featured in Scientific American, Science Magazine, and more. And lately, as you can imagine, he's focused on COVID-19 and is focused on vaccinology, coronavirus testing, mental health. We could not have a better moderator. We could not have a better panel. So thank you to everyone, and over to you, Angus.
Thank you, Tim. Well, so you guys are very lucky to have such an expert panel with us today. There's three. Galit Alter, who is a professor of medicine at Harvard Medical School. She's done a lot of work on understanding vaccine design and immunology. Charles Anderson, who is the president and CEO of the Dimock Center. Part of his work has been providing health services to underserved populations in the Boston area and advocating for health equity. And then finally, but not least, Claude Jacob, the Chief Public Health Officer at Cambridge Health Alliance. As such, he leads a major health operation for one of the most densely populated areas in New England. Welcome to all three of our panelists, and I guess we'll just jump right to it. So the first question is, I think, for you, Claude. One of the major questions that have been on, one of the major questions that's been on people's mind recently is just, when can I get vaccinated? Is it going to be soon? How can I find out? Should I be calling, Cambridge Health Alliance if that's where my GP is? What is the best way for people right now? Because I think it's been a little confusing lately. Claude, I think you are muted.
All right, there we go. Good evening. Thank you, Angus. Good evening to one and all. Happy New Year to one and all, because it's the first time that I'm seeing you. So, and to the French speakers, bonsoir. I would just say, Angus, as you well know, it's been quite an odyssey these last 11 months, full tilt on the ground dealing with this COVID storm. So I would say that being one of many, being the health officer here for these many years, I would just say that I can share with you one perspective, but also acknowledge that across the 351 separate cities and towns, there are different experiences that folks are having here in the Commonwealth. So let me at least acknowledge this has been quite a season, these many months. COVID fatigue, isolation fatigue, quarantine fatigue, all of that is real. But on the flip side, the infodemic, while we've been paying a lot of attention around the pandemic, there's a lot of information out there and some misinformation. So part of our task has been to figure out how to make sure that residents get the information in real time, just like the updates we provide every night, but also working very closely with our state level partners. So to your meta question around where are we today? Many of you may know, and I just want to make sure that the viewing audience recognizes that the state, thanks to our partners at the State Department of Public Health and through the governor's office, had released a schedule organized in 3 different phases based on different risk groups. So just know that as we speak, we're at the end of January, we're still in phase 1. And what that means is that the COVID facing, the healthcare workers, the first responders, all fit into that category, and there's quite a list. Just know that the chatter in the last day has been about phase 2, meaning the elderly, teachers, custodial staff, other folks that have some comorbidities, and where they may fit in the algorithm. So I would say to you that while there's a lot of information out there and we're trying to describe these different phases and risk groups, what we're tasked with doing as the local health department is to make sure that the information gets to residents in real time. So we'll talk more this evening, but I at least want to acknowledge we're a resource. We're one of many on the ground, and we're trying to at least make sure that we provide folks with the information so they can make the best decision, so they know where they fit in the schedule, but also more importantly, where they can go to get their COVID vaccination.
Claude, that it kind of reminds me, I believe the governor moved people who are ages 75 and older up in the priority list recently. So this is something that is sort of in motion as we speak. Does that kind of throw a wrench into your plans and make it more difficult for people to know where they are and get vaccinated?
Yeah, thank you, Angus. Again, and my colleagues will chime in as well. Yes, the news flash around the elderly, 75 years and older, and the 65 years and older, as well as, again, the list of folks that have comorbid conditions. So that has been the news that they are as part of the phase 2 priority groups. And it just means that we have an opportunity to make sure that they're at least front and center as being eligible for receiving the COVID vaccine. So effective February 1st, which is what's been hitting the airwaves, folks will be able to receive the COVID vaccine, whether it's at the retail pharmacies or even through these other mass vaccination sites. The slight wrinkle is that while local health departments have been engaged to vaccinate first responders within our respective jurisdictions, there's just a nuance to try to message accordingly so that seniors across our communities know exactly where they can go. So the situation continues to evolve, and that has been the biggest challenge tied to COVID. Every day is a different day. Every month is a different month. We talk about time soup. So Mondays, Wednesdays, Fridays, it's just all one and the same. We don't even talk about the days. And so that is part of the challenge with trying to make sure the right information gets to the right places so folks can feel comfortable and confident about the decisions they're making around receiving this vaccine.
It's a good message for people who are working on trying to schedule their appointments. Claude, I just one more question for you. So this is something that I think a lot of people have been hearing, that at the end of the day, clinics have excess doses. This is maybe sometimes because vials have an extra dose in them. And then people hear that they might be able to snag one of these leftover doses by hanging out outside of a clinic at the end of the day. I like to think of it as maybe like vaccine dumpster diving or dumpster diversion, maybe. Is that true, Claude? I mean, could you snag a dose if you are outside a clinic at the end of the day, if there's any left over?
Yeah, thanks, Angus. I'm humored by that, but I realize that this is a real serious issue. Again, vaccine hesitancy is real out there. There are folks who have had concerns and questions, but let me at least speak from the vantage point of what we've been able to do on the ground. So 2 weeks ago, we were able to activate Operation Nightingale, which was our way of vaccinating our first responders here in the city, police, fire, EMS. We were fortunate enough to make use of some available space over at the Cambridge Side Mall. And because it did require having an appointment, we tried to make sure to manage what we call a call list, just to make sure that we have folks at the ready who are part of the eligible group, but making sure that if we were looking at some extra doses towards the end of the shift, that we would make sure to get folks in to get their COVID vaccination. I'm proud to say that our team worked really hard, thanks to the fire department, the pro EMS, the paramedics, my fantastic team at the health department, and other partners like the police department, just to make sure that we were able to connect with folks. And what we had on average was about 200 COVID vaccinations each day over that 5-day period. So again, not standing outside the mall to get an extra COVID vaccine, but just making sure that we managed in like fashion, not just getting folks in and out after they were observed, after they got their COVID vaccine, but also making sure that we managed the call list so that we were very efficient in making sure that folks took advantage if they were willing to make their way to the mall and get their shot 2 weeks ago.
Yeah. You mentioned healthcare workers, first responders. There's been a lot of discussion on who gets the vaccine first. I think pretty much everyone agrees that healthcare workers and first responders should be the first in line. But implicit in that, I think, is this idea of fairness, like who should get the vaccine first. And Charles, I was hoping you could speak to this a little bit. How do we exactly balance the need for equity and risk when deciding who's in line?
This is a pretty hot topic right across the country, and so I'm glad you asked it. And it's something that we are trying to sort through. I mean, the reality is, when you think about the fact that there are parts of our society and individuals who don't have the option to work from home, right? 1 in 5 African Americans had the option to work from home. 1 in 6 Hispanics had the option to work from home. You start to look at that and you think about the fact that there's a population that are at higher risk. And the CDC was pretty clear as they looked at this and identified the fact that, an African American has a 1.5 times increased risk of contracting the virus, or because of that increased exposure, has a 4 times risk of being hospitalized and almost a 3 times risk of dying. So when you start to think about who should receive this first and who is most vulnerable, you can really make a good argument that there's some real vulnerability when you start to look along racial lines, and especially around racial lines in vulnerable communities like we serve in Roxbury. So, I do think there's got to be some thought placed to that. And the committee has been thinking about that. And part of what they have decided to do is to at least set aside 20% of the vaccines that are coming into the state for this population that we serve. Now, again, it's still using the same prioritization, but the reality, at least there's some thought to say, let's make sure that there's vaccine available for this population. Now, we also have to start thinking about vaccinators, vaccine sites. So there's still a lot of work there. But on top of that, and something we probably will get into a little later, is you have to get over this adoption issue. I mean, the reality is that deciding to do this, and it's a very complex decision, right, requires information. And unfortunately, I think we've been in a situation where, because of gaps in information, we have this very efficient system of disinformation and misinformation called social media. and that efficiency is quite honestly creating real challenges to get to that other aspect. So you asked the question about how should we be thinking about prioritization. There are some things in place to at least say, let's make sure the doses are available. At the same time, though, we have to be thinking about how we build trust and get across this adoption gap.
Yeah, it's something that I think that definitely want to touch on during this conversation in a bit. But I guess I just want to ask you, Charles, I mean, the way this is going from the top-down perspective, do you feel like the state has so far done a good job making sure that the way they're going about vaccinating is ethical?
Well, I think the challenge here is you start thinking about what is ethical, right? From my perspective, I have 19,000 people who rely on our services at the Dimock. And of those 19,000 people, we've done some analysis to say we've got about 10,000 doses that we need to do. And the reality is, so far, I've gotten 700. So, you can start to think about what that really means in terms of equity. And I'm going to have a number of people as we start February 1st who are going to follow that 65 plus category, and going to have 1 or 2 morbidities, sometimes 2 or 3 morbidities. So, if you start thinking about what's equitable, you can make a really good argument that there needs to be an increased range of thinking when it comes to making sure that the doses are going to be distributed in places where they're going to have the largest impact. And I do think we've got a lot more to do in terms of coming to that realization, and more importantly, actually making it happen.
Yeah. Now, there's another question about sort of prioritization that I've always personally wondered about. And Galit, maybe you could answer this. I've always kind of wondered if the way we go about prioritizing people to get the vaccine actually helps with our pandemic response. Is it better in terms of preventing cases or deaths this way than if it was just, a free-for-all?
That's a great question. So let me put out a couple controversial ideas to answer that question. So we use science to make decisions about how to deploy vaccines. We don't do it off the cuff. And I think that what's important to try to explain to the public and to the general population is really what science is being used to make these kinds of decisions. So epidemiology is the science of populations. It's the science of understanding how viruses spread across populations and where they cause disease. And just to add one more controversial concept to this is that we've been studying immunity for thousands of years, right? Edward Jenner began vaccinating in the late 1700s, but there was evidence of vaccination that dated back to the ancient Egyptians, the ancient Romans, and even ancient China. So we've been studying the populations that need to be vaccinated first for thousands of years. So the idea really is that when we're thinking about equitable distribution, when we're thinking about how we can have the largest impact on viral spread, we're thinking about putting the vaccine and standing up immunity in those that are most vulnerable to infection, those that are more likely to spread the disease, as well as those that are essentially more vulnerable to potential fatality following infection. So data has been collected throughout this pandemic since the beginning of the identification of the virus. And we've been trying to develop the models that tell us how we position this vaccine to have the largest impact on essentially slowing down spread. That is the essential data that we are using. It is all well informed, and governors in different states can take different strategies, but it's all based on the same epidemiological data that tells us that we can slow down the virus.
Oh, that's really fascinating. You know, I don't know if we could touch on this quickly, but just my almost gut reaction is that in some cases, maybe particularly in the COVID-19 pandemic, who is most likely to spread the vaccine, spread the virus, may not be the most likely to die from the virus. You know, we know young people are probably more active, they're out working, they're also less vulnerable to the disease than someone who's maybe 85, stays at home, and has, you know, two comorbidities. And so, I mean, from an epidemiological perspective, does that conflict maybe with our idea of who we want to protect first in the prioritization line of vaccinations?
Yeah, so maybe I can take a stab at it, and then maybe we can ask the others to respond. But I think that, you know, this is really a bit of the decision-making process, right? Which is potentially different from state to state. Where I think that many of us have placed our bets is that it might be more important to put the vaccines in those that are more likely to pass away from the disease, where we're prioritizing lives lost over the potential spread. So we're trying to understand how we can basically unburden the hospitals so that we can basically put the next line of vaccines and that wall of immunity up in those that are spreading that infection. There are lots of different ways that you can build the models, right? And a model is a model, and ultimately the data is going to, you know, we're going to see whether or not the strategy is the right strategy. But the idea is as quickly as possible, as we've seen now in Massachusetts, is stand up immunity in those that are more likely to end up in the hospitals, those that are more likely to potentially pass away from the infection, while helping to protect the physicians who are critical for providing that care. And the second line immunizations will go out to the populations that could be the super spreaders. Now, unfortunately or fortunately, you know, those who are also more vulnerable to disease or severe disease are also more likely to have high levels of viremia. And so I think often we underestimate, right, that even if you may not be as mobile as someone who may be younger, who may get infected, that often those individuals in nursing homes, individuals who are unfortunately not able to social distance, those individuals may have very high levels of viremia, making them potentially more likely to spread. And so we're tackling spread in multiple different ways by standing up this particular strategy for distribution.
I see. Well, actually, I'm going to move on to the next question just because of time. This is something I want to ask all the panelists here. I know that not everyone wants to actually get this vaccine. Some people are just unsure. So I thought I would ask all of you, have you been vaccinated yet? Do you plan to, and why? Maybe, I don't know, Claude, why don't you take it first, and then we'll move down the line.
Sure. Thanks, Angus. Yes, full disclosure, I've already received my first dose of vaccine, the Moderna vaccine. I get my second dose tomorrow. So I would just say that for me, being in this space, at least sharing with folks, I've had folks ask, well, what was it like? Did you grow an extra limb? You know, are you doing okay? I mean, so just trying to dispel the misnomers, but we know that each individual has different experiences tied to this, different comfort levels, but also physiologically may have a different reaction. So just know that that is the long answer to your question. But part of my task is to at least make sure that folks get the right information. There has been some chatter about the Pfizer vaccine versus Moderna. I'll defer to Dr. Alter and Dr. Anderson, but just know that we've at least tried to message this for residents on the ground, just to make sure they know where they can get the vaccine. And especially we had these questions with our first responders over the course of the last couple of weeks, and the area shelters where we have found some level of hesitancy among some of the shelter communities. So just acknowledging that, yes, and we are encouraging folks recognizing that it is a personal decision to receive the COVID vaccination.
Galit, I mean, have you got the vaccine yet?
Yeah, so I might be a little bit of an anomaly because I joined a phase 3 trial. So back in October, I decided that I wanted to be part of the mission of testing the safety and efficacy of the vaccines. And so I joined the Johnson & Johnson Janssen trial. I was fascinated by the concept of a single dose as being protective. We don't know yet what the efficacy will look like for that vaccine. Hopefully that will read out this week or next week. So fingers crossed. I feel good about my antibodies, but I joined the science part of the vaccine rollout.
Well, fingers crossed that you got the vaccine, not the placebo, I guess. What about you, Charles? Have you gotten the vaccine yet?
I have gotten the vaccine. I got the Moderna vaccine last week. So I've got my second dose coming up in a few weeks. And for me, you know, quite honestly, as this whole thing unfolded, I put myself in that category despite my, my just really passion about science. I did put myself in that initial hesitancy category, to be all honest. The reality, though, is that I had access to the information. So I was privileged enough to be able to have friends that I could call who were virologists and, big, at Big Pharma to really walk me through this. And it didn't take much, but the reality is some of that hesitancy is real. Right? Anytime you hear something that's called Operation Warp Speed, the question becomes, is it going too fast? Right? Anytime someone talks about DNA, RNA, whatever it may be, even me with my science background, it does make me think, is this something that's going to be a problem long term? These are realistic questions. And then, of course, the other remaining question, my family's from the Deep South. And, you grow up hearing a lot of the things about the experience there. I've grown up in healthcare. I've seen and unfortunately, witness the way that people are treated differently when they come in an emergency room or when they deliver a baby. And these are things that get ingrained in part of my experience that I bring to making this complex decision. What really got me over the hump, though, quite frankly, is one of my best friends in the world was one of the first 1,000 people to die from this in New York. And you know what? That makes it really, really real, really, really quickly. And when you start to really think about how this virus works, and you remind yourself about how the virus is the one that gets into the cells, takes over the cells, creates the sort of alterations, and in certain populations, the risk is so high, and I fell into that group of a high risk. So it was risk, benefits, and information that allowed me to make a decision.
Charles, thank you everyone for your answer. Charles, you reminded me that historically speaking, I guess the medical and scientific establishment hasn't always done the best thing to earn the trust of minority communities. Just to briefly, I mean, of course, the very classic example is the Tuskegee experiment. But there's lots of studies that to back up what you just said, that doctors don't always take, for example, Black pain as seriously. As a doctor who serves these communities, is that violation of trust a barrier to people getting this vaccine when it comes to these communities that we really most want to serve?
Absolutely. I mean, short answer is yes. Right. I mean, we're talking about, how to make this complex decision. It really requires trusted information. right? And if you can't trust the information and you really feel that you can kick the decision down the curb and wait to see how everybody else does, that's what you end up doing. So it is a huge barrier, and we're seeing it across the country. Right now, we see the difference in the adoption rates. We see the difference in vaccination rates by race and ethnicity. And it helps us really, really understand that this mistrust is a real issue.
Yeah. So what do you think? I guess how can we do things the right way when it comes to the COVID-19 vaccine and earning the trust of these communities?
Sure. Well, it's really interesting. Part of what I did, I am a doctor for pediatrics and newborn intensive care, but because of these complex issues, I found myself down various paths. Did the master's in public health, did an MBA, and I bring so much of that to bear as we think about this. This is really a very classic marketing issue, right? And part of it starts with you have to understand your target audience. What are the barriers? What are the messages? Who's the messenger? What are the channels? And we really have to take that approach. Some of the things we're doing at the Dimock is we're building a pretty elaborate ambassador program, utilizing figures in the community that are recognized, Black figures in the community, Latinx figures in the community that are recognized, and having them tell their story about how they arrived to where they are in the decision process. It's things like that. We have to think about what's the right voice and how that message gets voiced.
Yeah. Charles, there's a question for you from the audience from Susan. She wants to know if you would talk a little bit more about what your hesitancy about the vaccine was, and were there any facts in particular that helped you squelch your fears? In particular, anything that you know about the long-term effects of this vaccine, rather than sort of this more short-term acute effects like the nausea or what have you?
Sure. Well, let's be clear. We haven't seen anyone who's been vaccinated 10 years later. So we don't have that information, right? Now, that said, I still got to my place of decision on this. And quite honestly, I looked at the fact that, unfortunately, people are dying from this. And so I might not get to 10 years if I don't do something. But I will share a couple of key points that I think were very important in my process. One, the understanding that this messenger RNA, once it actually gets into the cells, which is just locally where the injection occurs, once it gets in, delivers the message, the protein is made, it disappears. It's not staying around in my system. That was one, made me feel a lot more comfortable. Two, it was only certain cells that could take that messenger RNA and do something with it. So it's not like it was going to be traveling around my bloodstream and stay around forever. Three, it's a synthetic product. It's not as if they're giving me something that is the COVID virus. So it's not, I don't have the risk of developing, COVID-19 infection from this. And I think those are a couple key ones. There are others, but those I think are really, really were some of the most important ones for me. And then it didn't alter my DNA. It had nothing to do with DNA, quite frankly. That's a big one.
All right. Well, thank you for sharing that. And since you bring up fears, it kind of helps us seg into our next topic, which is generally, I guess, health and safety concerns about this vaccine. There's been a lot of rumors, and I guess I should really say misinformation about this vaccine that's out there. I have actually an anecdote. My colleague, another reporter at WBUR, was getting his haircut, and his stylist told him that the vaccine would put a microchip in you and tag you for like the New World Order or something, which is I think we can safely say is not true. There's also a rumor that it causes sterility or it's not safe in other ways. Galit, I guess from the immunological perspective, what evidence is there to suggest that these vaccines aren't safe and should be avoided? Oh, you are muted.
There we go. That's a great question, Angus. And I think this is really important to start to dispel some of these rumors that are coming around. So I think that what is clear is that we've actually been putting RNA into humans for some time. We've not used them for vaccines, but it's been used as a therapeutic for many other diseases. And so we have a tremendous amount of experience, both preclinically as well clinically, with this type of molecule. It is a very safe product. And we know, most importantly, that it's fast, it's reliable, and it's incredibly simple in how it works immunologically in the system. Our body naturally uses RNA as a message system. It essentially provides instructions to the cell on how to make proteins, nothing else, nothing more. It's a very simple way of essentially providing software to cells to essentially make one protein and one protein only. So this misconception that other things can get produced by this RNA or that it could derail the cellular immune response, there is really zero evidence immunologically, biochemically, or at a cell-based mechanistic level that could ever substantiate those kinds of claims. There certainly are no microchips. It is literally just 4 different nucleotides that are strung together in a particular sequence. These are sugars that essentially make the message that is our RNA. And what it is this little message that we put into the cells, essentially just tell our cells how to make this one protein that really has 0 functions within the cell other than to essentially be produced by these cells of the immune system that can then drive immunological immune responses that then produce antibodies and T cells that confer protection for at least a few months, if not for life, against that pathogen. So I think that if folks have these kinds of questions, and Angus, if you ever hear these kinds of questions, we just have to do a quick Google search. For reliable sources of information, I recommend PubMed. It's a very good source of information, and not The Onion or other funny places where we can get funny sources of information. So I hope that that information helps to dispel those rumors.
You know, the other big one was where the protein, what happens when the protein, when it's made, right? Right. It is because one thing that people often think is that the protein is now going to circulate around the body and lodge in various places, but the idea that the protein is just expressed on that cell.
Well, okay, so this is a really important point, you know, about how the actual process works, right? So essentially what we're doing is we're providing software to the cell. The cell takes that software. It's not hardware. It can't go into the DNA. It gets trapped out of the nucleus. The nucleus protects itself. Almost nothing can get in there. So you now have software that's inside the cell that can now produce a protein. That protein is then expelled from the cell. And we're talking about a trickle of protein, a tiny little amount. We're not talking about milligrams or grams of protein. We're talking about just enough that that can get picked up by other immune cells that are in that local environment that then travel to immune inductive sites where they can essentially teach the immune system on how to make these critical responses like antibodies and T cells that fight the infection. It is not a persistent production of protein. It's literally just a trickle. And this is why it's so important to have 2 doses of the vaccine, because you get 1 trickle the first time. That trickle gives you just enough to tickle the immune system and kickstart that immune response. And then when you come in with the boost, that second trickle reminds the immune system that it essentially has to go bigger and make a response that's going to last for a long period of time. So those proteins really are coming in at small amounts, but just enough to drive the level of immunity that is critical to protect us against this virus.
You know, there's an audience question that relates to that, Galit. If you want to take it. Someone from the audience, Christine R., asked if the vaccine will prevent her from getting COVID or just lessen the symptoms if she becomes infected or encounters the coronavirus. Is there, I guess, you know, what is the answer to this?
So that's a really great question. So that is, you know, that is really the ultimate question. So when we were rolling out the phase 3s, Operation Warp Speed, some decisions were made about what the primary clinical endpoints would look like that would help with the licensure of vaccine. There were additional clinical endpoints that were captured within the phase 3 trial design that would ask other questions related to potential transmission and protection from infection. So the priority question was, can we stop people from getting really sick and ending up in the hospital, right? That was our primary goal, was to essentially slow down the burden of this viral disease at a population level. So that was the clinical endpoint that we saw at the time of licensure. If a vaccine was able to stop people from having to go to the hospital and develop severe disease, that was an incredible win. We had no idea we would end up with 95% reduction of severity of disease. Now, the secondary endpoint that we've been looking at is whether or not people are actually getting infected, not just if they develop disease. And so that is being measured with a different type of immunological readout. And there are really intense sampling studies that are going on right now across the country and across the world to address that very question. What I can tell you is, at least from the preclinical data that comes from animal models, it is clear that with 2 doses of many of these vaccines, we not only prevent severity of disease, but also infection completely. How long that protection will last, that is the big question. But that is exactly what we're trying to answer in the next few months with these intense sampling and immunological studies that are ongoing in the wake of this licensure and deployment of vaccines.
We have a few more questions from the audience that I would love to get to, but there's one thing I did want to ask you, Galit, is maybe sort of tails on to that existential question about the vaccine. Recently, we've seen the emergence of a bunch of, or I guess a few new variants of the SARS-CoV-2 virus. And there's always a question of whether a variant will arise that has some kind of resistance to the vaccine's protection. What's your take on this? Is this really a danger right now to our vaccine efforts? And does the emergence of these new strains or variants, I guess, mean that the pandemic will just never end? Let me unmute Galit. Let's see.
Here we go again. Okay, so I'm a virologist at heart. It is not surprising that viruses evolve and mutate. This is their job. This is like every species of life on Earth. We try to evolve in the wake of obstacles around us. So the evolution of mutants and variants is not surprising to the common virologist, and we were anticipating that this was going to happen. Now, what I have to say about the mutants is that some of the mutants that have arisen seem to still be vulnerable to the vaccines that we have out there in population deployment. But there are some concerns about some of the newer mutants that are being described that are coming up in Brazil, as well as South Africa and other parts of the world. We don't know what fatality will look like in the wake of these mutants. We don't know how well the vaccines are going to protect. The first data that hopefully many have seen on CNN is that the vaccines still do seem to provide some level of protection against these viruses. And that is the best news that I woke up to this morning when I read the news from Moderna and Pfizer. But what this means is that we have to be vigilant. And I think that this means that, we cannot just assume that all of our problems will be solved as soon as, a portion of the population is vaccinated. We are likely going to be wearing masks for a little bit longer than just the moment that we are vaccinated. And we have to keep monitoring this virus, because it's not that the vaccine can essentially be deployed to the entire population within a matter of days. And so I think that the news is that it's not surprising, right, that these viruses do this. This is their job. This is their livelihood. But it is our responsibility to be responsible in how we deploy the vaccine. It is our duty to be responsible in how we educate the public, to tell them you have to wear masks. That is the #1 intervention that we have currently. And even though we have the hope of a vaccine right now, we don't really understand how long the vaccines will fully protect us against variants, although we are very hopeful that we are on our way to really battling and vanquishing this particular virus.
Yeah, I think that's a really great note to end on. I spoke with a clinician earlier today who said we're finally moving on the offensive with this virus, rather being on the defensive as we have for the past year. Well, I want to thank all 3 of our wonderful panelists today. I'm going to turn it over to Tim Ritchie, the president of the Museum of Science, and Galit Alter, Charles Anderson, Claude Jacob. Thank you all so much for taking your time today to speak with us.
Thank you.
Thanks, Angus.
Let's see.
Sorry, I was muted by the host. We just couldn't get there quite fast enough. And I think I'm also unable to show you my face. But I will say this. Thank you so much to Galit, to Claude, to Charles, and to Angus. This is what we're about, and where we protect ourselves through knowledge. We protect ourselves through knowledge. And this was the knowledge that we needed, and we're grateful for your service. And now I'd like to turn it over to Emily Hostetler for instructions about joining the breakout sessions. So over to you, Emily.
Hi, everyone. And I think we can work on unpinning some folks here, but we'll put up our slide there. Thank you, Tim, and thank you, Angus, and thank you to all of our wonderful speakers today. And thank you to all of you for joining us who are asked such amazing questions. You're really thinking quite deeply about all of this. And it's been so wonderful to see what you're thinking about and hear from our moderators from their responses. So like Tim said at the beginning of our event today, this event is the first of 3 town halls in a series focused on vaccination decisions. We hope to see you again on February 23rd when we discuss clinical trials, and again on March 23rd when we discuss what the future may hold post-COVID-19. Next, we will be moving into breakout rooms to discuss the 2 questions that we'll put up on screen shortly. We are happy to be able to actually offer you who stay for our breakout room discussions a $25 Amex gift card who are able to stay and participate just as a way to thank you for sharing your knowledge and voices with us. However, if you do not wish to participate and you would like to have the rest of your night to yourself, it's only a 30-minute conversation, but if you would not like to join us and move on and leave us today, we thank you, of course, for watching and learning with us, and we hope to see you very soon. If you are not interested in those breakout conversations, you can now log off. And again, thank you so much for joining us for the panel discussion.